All right, we ready? The nurse should be most concerned about the presence of subinvolution if which occurs. All right, so Alicia was just talking about how subinvolution is definitely like you think about like maybe infection like endometritis, right? But also retained placental fragments can cause subinvolution. Do you guys remember what subinvolution is?
It's when the uterus cannot return back to its original form.
Yeah, good. So it's not able to go back down to where it lived before, and it's because something is keeping it from doing so. And so retained placental fragments could be in there, or we could have infection in there. And the most common infection in the postpartum period happens in the uterus. And what's the name of it?
What'd you say?
What's the name of the infection in the uterus after delivery?
Endometritis. Hold on, no.
No, you're
Yeah.
right.
Good morning. For me, I don't know. You want to start at T?
So endometritis is the name of that infection. Um, what could we do to help decrease the risk of endometritis, especially like if she has a C-section?
Would it be antibiotics and massage the fundus?
So we're going to give antibiotics if she has a C-section to try to reduce the risk of developing endometritis after delivery because endometritis originates where that placenta was attached on the endometrium. And when we open the uterus, like with the C-section, we are increasing our risk of exposing bacteria to the site. So that's why we give antibiotics with C-sections, and that's what we're trying to avoid. So if we had subinvolution, so it says the nurse should be most concerned about the presence of subinvolution. What might make a nurse think that a patient has subinvolution?
With silk involution, it'll be bleeding. What else?
And maybe it's
What
shifted over.
that
What did you
that
say?
I
I
said that
said
the
what
uterus isn't returning back to its normal state,
Right.
and then she's had some hemorrhaging, and maybe it's boggy.
Okay. Yeah. So bleeding. Also, we can see return to rubra. So remember the process of our discharge is going to be rubra, serosa, alba. If it goes to serosa but comes back to rubra, that can be a sign. An enlarging uterus. If you expect, like for normal involution, how much should the uterus go down each day?
1 centimeter.
Mm-hmm. And so if you are assessing a patient and her uterus is enlarged, it's larger than you anticipate based on how many days out she is from delivery, that can be a sign. So there's kind of a lot of different things that go into this. So you can see like heavy bleeding. You can see return to rubra. You can see an enlarged uterus. Um, any of those things could be indications of subinvolution. And this is where we can have what's called the late postpartum hemorrhage. So that is concerning. The nurse notes the client has decreased urinary output, pallor, and tachycardia. What action should the nurse take? What do we think of your decreased urinary output, pallor, and tachycardia?
I want to say, hold on, I'm thinking of the word. I want to say, no, it's not preeclampsia. Hold on. We tachycardia, we're paler, yeah, decrease. I know this. It's, it's not, hold on. Wouldn't it be No. Oh, I know this one. It says for
There's a big
hypovolemia.
hint in the answer because it says hypovolemia.
Mm-hmm. So that means when you're hypovolemic, that means you're having fluid volume deficit. Um, says for hypovolemia because she's having decrease of it. That means she's not getting in enough fluids. Oh, I'm all over the
Mm,
place. So,
or maybe she has gotten enough fluids, but something's happening to it. This is going to be something that would be common with a hemorrhage. So decreased urinary output because we're not perfusing our kidneys well if we've been bleeding. Pallor because less blood. Tachycardia is, remember, that's our first vital sign change with hemorrhage, is the heart rate goes up even before we see anything else. Okay. Monitoring a client in the fourth stage of labor, which may indicate the presence of a laceration in the birth canal. All right, let's talk about this one. So if we're monitoring and we think there might be a laceration, the key to this would be if we're seeing bleeding, but when we palpate, because usually, guys, if we're bleeding, what's the first thing to do?
assess for the saturation of the pads if
So
you're
we
bleeding.
went in and we found a saturated pad. What should you do?
Will we just call a provider being that the pads are saturated and we have some bleeding?
Well, we're probably going to
Oh,
need to
hold on.
call the provider. But is calling the provider the good first thing to do?
No, the good second thing. Oh, what? I'm going blank. I know the answer to this. I'm just going blank right now. I'm trying to
Maybe
think of.
assess the patient to see if you
Oh,
can see where the bleeding is coming from.
okay. And so you walked in, she's just laying in this bloody mess. And so how could I have a good idea where the bleeding is coming from? So you said assess the patient. What would be the first thing to assess?
It would be her
Her vagina.
wouldn't it?
Um,
Because you want to make sure that that it's nice and firm and not boggy.
so that's going to be the good first thing. So we before we even look and to like see if she has laceration, the first thing, remember guys, that the number one cause of bleeding in the immediate postpartum period is uterine atony, which means uterus isn't contracting well. So we should first assess the uterus, okay? Which brings us back to massage the fundus. So if you feel to massage the fundus and it feels firm, now we think it could be a laceration, right?
Mhm.
In order to really see a laceration, that we probably do need a provider for, because oftentimes these are inside and they might even have to use a speculum to look. So, but if first thing, if I walked in and I saw a bloody mess and I went, all right, hold on. And I went out and I called the doc and I said, hey, she's got like a whole bunch of blood on her pad. If it was her uterus, in the meantime, she's just hosing blood. So it's still better to massage the fundus first, and then you'll have an idea if it's her uterus or if it's something else, and then go from there. So for this patient, she had a firm fundus. So then we think, well, then where's the blood coming from? If it's not her uterus, it's probably laceration. If it was her uterus, if her uterus was boggy, how do we treat it? Actually, let's talk about this for another second. If it wasn't a laceration, if I checked her fundus and it was boggy and I started massaging it, then what else would we do?
Say the question again, please.
If I went in to assess my patient, she's laying in a pool of blood, and I checked her fundus, and in the question on the game, the fundus was firm. But let's say it's not. Let's say it's boggy. And I start massaging it. What else are we going to consider doing for a patient that has uterine atony?
Is that when we would start Pitocin as well to give her to help make the uterus contract?
Yeah, we could give her Pitocin. Okay, remember for uterine atony, we're going to massage, we're going to give medications, we're going to manage the bladder. Okay, so I'm massaging, and maybe I call out for help because I have a lot of blood happening, and my friend comes and can hang Pitocin, and then what else then should happen? Maybe we should manage the bladder. And so if we put in a Foley catheter or we do a straight cath and we empty her bladder, because that's one thing that could cause uterine atony. If we're still bleeding, we might consider other medicines besides just Pitocin. So what other medicines could we give?
Cytotec.
It started at 8. Hemabate
Hemabate?
and one more. Oh, it was Epitocin, my
Is
Metrogen.
Tabuta? Is it to?
Medmetrogen.
Hi.
So we're going to do Pitocin, Cytotec, Hemabate, Metrogen. Okay. Metrogen is contraindicated for who?
Hypertension.
Hemabate is contraindicated for who?
Asthma.
Good. Yep, good. For this patient in our actual question on the game, she didn't have uterine atony though, right? It says the uterus is firm, but the pad is saturated. So if you check the fundus and it's firm, then we think it's a laceration. And then our uterotonics aren't going to help. None of those things are going to help. We need to have the provider look in her vagina and repair it. A postpartum patient was in labor for 30 hours with ruptured membranes for 24 hours. Which would the nurse anticipate? Okay, so let's talk about why this isn't chorioamnionitis. Any idea why chorioamnionitis wasn't correct?
Same symptoms of it, maybe?
Say that again?
Was it because she didn't Like she didn't display any symptoms of the hormone.
No, she's postpartum.
It's because she's postpartum now. So chorioamnion. So the story of being in labor for 30 hours with ruptured membranes for 24 hours definitely puts her at risk for chorioamnionitis. But the thing that's infected with chorioamnionitis is the membranes. Okay, so the membranes are the chorion and the amnion that surround the baby and like make that water balloon, right? It attaches to the placenta and goes all the way around. So with chorioamnionitis, that infection is the membranes and the amniotic fluid. She's not pregnant anymore. Okay, she's postpartum. So her infection probably still is in the uterus, but now it's probably again at the endometrium at the attachment site from the placenta. So when she has been ruptured for a long time, she has this increased risk of not just having it chorioamnionitis, but then also developing endometritis after delivery. Does that make sense? We lost Brandy. The nurse notices a newborn has a large cephalohematoma at 24 hours of life. What intervention has the highest priority? Okay, assess for jaundice. Why do we want to assess for jaundice? Somebody picked it. So if we have a baby that has a cephalohematoma, cephalo is head, hematoma is blood, right? And so that blood is going to need to be broken down. And when it breaks down, it's going to release bilirubin. And that's going to increase the risk for jaundice for the baby. When we think about what we might see if our baby develops jaundice, the bilirubin level will be going up. But what else might we see?
When we're assessing for jaundice,
Mm-hmm.
we're gonna see yellowing of the skin.
Yeah. Okay. So we can also see yellowing of the skin. All right. Other things with babies with jaundice is they can be lethargic and not feed well and things like that. But the big thing we'll be able to visually see is going to be the yellowing of the skin. But for this baby, we're going to be monitoring their bilirubin levels anyway because of the cephalohematoma. How would we treat it if the baby develops jaundice?
Phototherapy.
Phototherapy. What's important considerations, nursing considerations for phototherapy?
Only a
To put on the little things over
and
their eyes,
goggles.
to shield their eyes.
Good. Yep, we need to cover their eyes, protect their eyes. Okay. We're gonna have them just stripped down to a diaper so that as much skin as possible is exposed. And then depending on if they're using like the overhead light, or there's something called a billy blanket that just kind of wraps around the baby, then sometimes we can just keep them in the blanket, even for like mom holding and breastfeeding and stuff like that. But otherwise, we want to minimize times that the baby's not under the lights. Okay, so if the baby is under just like the overhead light, then we'll minimize the times that the baby's not under it. Okay. Brandy's back. Are you able to still be in the game?
Yes, my computer died. It's still there.
I just didn't know if you got kicked out of the game. The nurse is caring for a breastfed newborn. What will the nurse expect the stool color to be 5 days after birth? Good. Yep. So by 5 days after birth, we should have transitioned to this breastfed baby stool, which is yellow and seedy. Okay. What does it look like at the beginning? What does newborn stool look like at first?
Like it's more like a green.
It's that black tarry,
It's more of a black and tarry color.
yep, and that's the
The
meconium.
meconium.
Yep, and then it's going to transition to, it'll do like a greenish yellow, and then it'll go to yellow and seedy.
I'm not ready for those blowouts.
Well, and those breastfed baby stools, like it like can project out of them. I know I
It
was holding
does.
my
It goes
baby and I
all up the
like,
back.
yes, and I picked him up to get the diaper off from under him, and it went and shot across the room. The kid like target practice.
I'm not ready for that.
Hmm. The postterm neonate at 42 weeks and 3 days with meconium stained amniotic fluid needs care designed to monitor for which of the following? Ooh, it went too fast. I wonder if it'll sit here for a minute. No. I wanted to pause. I want to talk about respiratory distress. Well, we'll come back to it in a minute. What will the nurse expect when assessing the anterior fontanelle of a healthy full-term newborn? Stop. Okay. For this one, yes, the anterior fontanelle is up here. It should be soft, flat. It's also shaped like a diamond. Okay. If it isn't soft and flat, if it's sunken in, what could that be a sign of?
Dehydration.
Okay. And if it's bulging out,
Uh, hematoma.
not a hematoma.
I'm calling for a friend.
Nobody else is answering. If it's bulging, that can be a sign of intracranial pressure.
Okay.
Okay, so sunken for dehydration, bulging for intracranial pressure. The previous question that I didn't pause it fast enough had to do with meconium aspiration, and I wanted to talk about what that looks like as far as respiratory distress for our baby. So, what are our signs of respiratory distress?
Nasal flaring.
Mhm.
Tachycardia.
So maybe tachycardia, but mostly tachypnea. So
Oh
the
yeah,
thing that's fast is the breathing.
Okay, yeah. I was so increased respiration rates.
Yep,
Um, those are two I got on top of my head.
yep. So tachypnea is a big one. Greater than how fast?
60?
Mm-hmm.
Facts.
Okay, greater than 60. Brandy, what were you going to add?
I was just gonna say some grunting.
Mm-hmm. Grunty. Anything else?
Nothing.
Did we say the use of accessory muscles already?
Nope, we didn't say that yet. So with the use of accessory muscles, we can see like retractions.
I'm sorry.
The other thing, guys, is the seesaw breathing. And so babies are abdominal breathers, and so their bellies and their chest should rise and fall together. So if they're alternating like this, like a seesaw, then they're working hard. So that's another one. Good. Parents of a newborn ask about dark areas over the sacrum. What does the nurse explain that this is called? Yep. So the dark areas over the sacrum are called Mongolian spots. It's a good idea to document these because they'll fade over time, but they don't always go away and they can look like bruises. Okay, so it's good to have them documented because that helps to be able to tease out if there's any concerns for safety for our baby. Okay, other things that are on the slide. What is milia?
Are those the white spots around the face or nose or
Yep.
something?
Yep, they're little white spots on the nose. My youngest son had them horribly. You really just kind of want to pick at them, but you should leave them alone. What about nevus simplex?
Is that the indentation on the nose, the indentation spots?
Not for this. The nevus simplex is also called the stork bites. Does that help you think about it, like what it could be? This one, the nevus simplex, I can see if I can show you guys what it looks like. It is like um the pink. It's usually back here. Let me see if I can get a picture.
I'm looking it up now too. Oh, okay, yeah. It's on the back of the neck,
So
on
it's
the
most
forehead.
often on the nape of the neck, but like when I just put in a search right now, I see lots of different, like forehead, up here. Sometimes we do see it here. My boys have it back on the back of the nape of their neck. They both do.
Okay.
Okay. And then while we're here, we can look up the other one was Epstein pearls. And so these are these little white spots on the gums. So some of these are showing us teeth, but we're really looking at these little white spots. And this is also not a concerning finding. Okay. Something else that wasn't on the slide that's a skin one is erythema toxicum. And I feel like I talk to parents about this all weekly. So this is newborn rash. Oh, I didn't pull the picture up bigger. But it looks like this. So it's red and blotchy, and it can even have like little dots in it. And that's really also very normal as well. This one pediatrician that I work with, he talks about how babies have been living in an aquarium, like a fish, and now they have to adjust to being a land animal, and which is kind of silly, but the skin it's a big change for the skin to go from being in the amniotic fluid to being out in the air, so they can get this rashy stuff on them. Yeah, okay. Like, is there any other skin things we should look at? But those are the big ones, I think. All right. So back to our game. Parents ask the nursery staff what the light does for their jaundiced infant. What's the nurse's best response? Good. Yep, and we just talked about this already about the use of phototherapy for our baby that had a cephalohematoma that might develop jaundice that we would need to potentially do phototherapy. And with phototherapy, though, what exactly is it going to do? Like it says it breaks down the bilirubin, but it's going to take, I think about it like big chunks. So our bilirubin is unconjugated, it's flowing through, and it's really hard for babies to excrete that. So it conjugates it or breaks it down so that they can excrete it. And then how do they excrete it?
In their poop.
hmm So we also want to get them eating so that they're subsequently pooping. Which of these medications used for bleeding is contraindicated in a patient with asthma? Yep. Okay, hemabate is contraindicated with asthma. Methotrexate is contraindicated with
Blood
Hypertension.
pressure.
Yep. But let's pause for a second. Hi, Tamika. Let me give you the link to the game we're playing. I just put it in the chat so you can click it. Did you get it? I'm going to go ahead and keep moving. Oh, she's in. Okay, good. A newborn who has an asymmetrical moral reflex response should be further assessed for which of the following? All right, let's talk about this one. Asymmetric moral reflex. So how do we elicit the moral reflex? What is the moral reflex?
Is
Is
it
that the one where you started him?
the back? It's like a startle.
Mm-hmm.
Uh,
Mm-hmm. Okay. So it's also known as the startle reflex. And so if we are just hold onto their hands and just pull up just a little bit and let go, they'll go like this. It's like they feel like they might fall. Okay. But when they do that, their arms come up and this should be equal. All right. If you have an asymmetric response, then it's not equal. And so that makes us worry that maybe something's going on with the side that didn't respond the same. All right. And so oftentimes this can be a sign of a clavicle fracture. Because if they have a fractured clavicle, it's painful and they start to come up and they kind of guard it. All right. So this side can still move with a clavicle fracture, but it's going to be guarded. All right. Now, if they had no response on this side, on whatever the affected side is, for some reason I always point to the left. If they have no response, then what could that be? I have to go like this to lower my hand. There we go. So if we have an unequal response, that could be clavicle fracture. If we have no response, what could that be?
maybe like a neurological issue going on. But I
So
don't know.
it's going to be related to, it's going to be a nerve thing, but it's the thing that we're concerned about is a brachial plexus injury. And the brachial plexus injury is going to be where we have either stretching or tearing of the brachial plexus. And does anybody remember the most common time that happens? I think you guys know this. What's the most common time that we see a clavicle fracture?
Doing shoulder dystocia.
Hmm. And that's also the most common time we'll see the brachial plexus injury. So
Mm-hmm.
with the clavicle fracture, that often happens with the suprapubic pressure that we might have to do with a shoulder dystocia. The brachial plexus injury also happens with a shoulder dystocia if we see it, because that if they're putting a lot of traction on that, they're pulling on the head and trying to pull downward to try to get the shoulder to come underneath the pubic bone, it can stretch or tear the brachial plexus. Okay. And so this one is going to have no movement when you do the Mohr reflex. Okay, so in the question, we had asymmetrical movement, so that's clavicle. Which newborn should the nurse recognize as being most at risk for developing respiratory distress syndrome? Okay, let's talk about this one. In my classes, I tried to talk about and differentiate the difference between respiratory distress symptoms and respiratory distress as a syndrome. Okay, the symptoms are the same, but as a syndrome, it is caused by, does anybody remember what it's caused by? I have a couple of my students in here. Do you guys remember? Or even not my students. Do you know what respiratory distress syndrome is caused by?
Can it be caused by like a
Is it
baby?
prematurity?
Bridge, say, what did you say?
I was gonna say maybe a big baby. I'm gonna say macrosomia baby, right?
And then,
Maybe.
Tamika, what did you say?
Premature babies? Prematurity? Preterm?
So it's really going to be more something that we see with your preterm babies. And here's why. So the reason is because the syndrome is because you have a lack of surfactant. Like that is what's causing the baby to have respiratory distress, is a lack of surfactant. So, but Bridget, I think that your thinking is on the right track, because we also talked about it in relation to moms that have poor glycemic control that are diabetic, that those babies also can have a lack of surfactant. So then you have a big baby that breathes like a pretermer. So with that respiratory distress syndrome specifically, we have a lack of surfactant in their lungs. And so that's why when we look at the choices for this, 39 weeks, gestation newborn delivered vaginally isn't it. 35 weeks, newborn delivered vaginally from a mother addicted to heroin. The fact that she's addicted to heroin isn't going to have any basis for this. And 35 weeks, we anticipate there's sufficient surfactant by 35 weeks. Okay. If I had to choose one and all the other babies were term, I'd pick 35 weeks, because that would be the one that'd be most likely to have insufficient surfactant. But this guy is 27 weeks, so this one's definitely going to have a higher risk. All right. For babies that have insufficient surfactant, we can give surfactant back. So surfactant reminds me of, I don't even know if you can do this anymore, so this isn't maybe even helpful, but used to be able to, if you went and you bought balloons, they could put this stuff in it called high flow and rub it in, and it was this slippery stuff that would keep your balloons holding their helium longer. And I think a surfactant like that it's the slippery stuff that helps keep those alveoli open so they don't collapse down on themselves. So your babies, especially preterm babies, have a higher risk of having atelectasis, where it's hard for them to keep those little air sacs open. And so, because they don't have as much surfactant in there. Does that make sense? Yes, no?
Kind of.
When everybody's camera's off, I feel like I'm just talking to myself. So basically, surfactant's going to help keep the alveoli open.
Yes, it makes sense. I'm sorry, I'm at work, so
Okay.
but it does make sense.
Okay. It's going to help keep the alveoli open. If your baby is preterm and they don't have enough surfactant, that's respiratory distress syndrome. And then we can actually put in an endotracheal tube and put surfactant into their lungs. And sometimes that's necessary as well. And it makes a huge difference, like almost right away. Which findings are not signs of withdrawal in the newborn? Okay, so it says which is not. Everything on here is, except for green. Tremors, diaphoresis, frequent yawning, frequent sneezing, high-pitched cry, hyperreflexia. So for this, everything is excitable. Okay, so when we first got in here today, Alicia was talking about how she was remembering that with magnesium, I talked about how everything slows down. So for this, for your newborn that's withdrawing from drugs, everything is up here. Everything's excitable. Okay, and so any answers that are down here aren't it. So they're not lethargic. They're not hypotonic. Everything's excitable. Okay. And so hyperreflexia, high-pitched cry, tremors, diaphoresis, all of those things, we see that. Also frequent yawning, frequent sneezing, okay, are all signs of newborn withdrawal. Which of the following actions would be least effective in maintaining a neutral thermal environment for the newborn? So which is least effective? Okay, so placing the crib close to the nursery window would be least effective because that has the possibility of being drafty and the baby could get cold. We want to maintain that neutral thermal environment. Basically, we don't want our baby to get cold. Okay. All of these other ones are going to be aimed at keeping our baby warm. A newborn's temp is 96.8 degrees Fahrenheit. His lower lip is shaking. His hands quiver when we assess the moral reflex. What do you think we need to do for this baby? Okay. So for those of you that chose red, what made you think that we need to check the glucose?
His hands quiver when assessing. Lower lip is shaking. His temp is 96.8. When everything, the reason why I chose it is because every other answer does not help me really understand what's going on. So I'm going to assess that glucose just to make sure that his blood glucose levels have not dropped. You know, something to assess, something that I can clearly rule out. That was my whole issue of picking that answer.
Okay. Anybody else?
I've had this experience in clinicals with a newborn. Now the mother didn't have no prenatal care, a young
Mm-hmm.
19-year-old mother, and the baby showed these exact symptoms, but the baby's temp was a little tad bit lower, and his glucose was like 30 something.
Okay.
So that's how I knew the answer. So
Okay.
yeah.
Yeah, so the temp is a clue. That can be a clue that the sugar's low because that you can definitely see temperature instability with hypoglycemia. Also, hypoglycemia can or hypoglycemia can happen because that the temperature is low. Because if we think about cold stress and non-shivering thermogenesis, the baby starts burning their own brown fat to get warm. So if the baby gets cold and they start burning their own brown fat, it goes down this cascade that can also cause hypoglycemia. So if your baby's cold, it's a good idea to check the blood sugar anyway. But then we also have the lower lip is shaking and the hands are quivering. So these are signs of jitteriness. And jitteriness is a really common sign of hypoglycemia in the newborn. Okay. What is the nurse's best response to a mother who's voicing concern about the molding of her 2-day-old infant? Okay, so yes, the molding is normal. Okay, and it'll go away on its own. All right. So we're going to reassure her that this is a normal finding just because remember that the bones of the head aren't fused and so they move to adjust to fit. The other thing we can see with this that's really normal that goes along with the molding is going to be maybe some swelling at the where the presenting part was coming through the birth canal. And this swelling crosses suture lines, is superficial. Does anybody know what I'm thinking of? Starts with a C. Nobody? Crosses the suture lines, swelling on the top of the baby's head that crosses the suture lines and is normal. Okay, so this is caput. Okay.
You know, I
Um,
I knew that, but I didn't want to put. I'm like, maybe I'm wrong. I was going to type it in the chat.
well, you could still say it is just the four of us.
I don't like
So
to be
what if you're
wrong, so
wrong? So what if you're wrong? This is the perfect time to be wrong. Because then if you say something that's not right, then we can talk about it. And then if you see it on your test, you'll be like, oh yeah, we talked about this. I remember. Yep. So kappa is going to be something we see that often goes along with molding. So the molding happens as the bones shift, and then you can see some caput or some swelling on the part that was coming through the birth canal presenting first. It crosses the suture lines. It's also going to just go away in a few days. And I remember caput like a cap, right? Because if you put on a cap, it like encompasses that whole top part of the head. And so it's fine. Our cephalohematoma is the one we're concerned about because that's the one that doesn't cross the suture lines, and that's the blood one that we already talked about can cause jaundice. But for kappa, it's totally fine. If you have a baby that had like a vacuum delivery, That can cause caput because the pressure that happens with the vacuum can just kind of pull some of that edema to that spot. But it also could cause a cephalohematoma. So we have to be able to differentiate between if it's crossing the suture lines or not. But oftentimes I'll see molding and cap it with a vacuum. But I just make sure that it's not crossing the suture line because then I'm worried about cephalohematoma. Does that make sense? When assessing the male infant, the nurse notes enlarged testicles that glow when the light is shown below them. The nurse identifies this as what? Yep, this is a hydrocele. So a hydrocele is an accumulation of fluid in the testicles. So when we're assessing a newborn boy, we look at the testicles for a few things. We want to know if the testes are descended. Okay. Cryptocorticism that I can't really pronounce is if they don't descend. And that's pretty more common like with your preterm baby. With your term baby, you should be able to palpate and feel the testicles on both sides. Okay. If they're really enlarged, then we'll try to shine the light under to see if there's fluid in there, which is the hydrocele. If the urinary meatus is not at the tip, that's another thing we look for. And that's what this is talking about with hypospadias and epispadias. Okay. If it's hypospadias, the opening is underneath the penis. And if it's epispadias, it's at the top. What considerations might we have if we have a hypospadias or an epispadias? Hmm. If the urinary meatus is not at the tip of the penis, they won't circumcise the baby because they'll need to use the foreskin potentially to rectify that. And then testicular torsion, if we have one side that's larger or discolored, that we could be concerned about torsion as well. The nurse is caring for a macrosomic newborn whose mother has diabetes. What should the nurse assess for? Yep. What else? So besides watching for hypoglycemia, what else are we going to assess this baby for? How about, oh, we're gonna go in the
Seizures?
chat. So in the chat, respiratory. So remember we talked about how babies that are born that don't have enough surfactant can have respiratory distress syndrome. And that's usually your preterm baby, but it also could be your baby born to a diabetic mom because for the same reason these babies can be hypoglycemic. So if a mom has diabetes and she's not controlling her blood sugars well, and so we talked about that in week 5 about doing finger sticks and choosing healthy carbs and exercising and all those things that we learned about. If she's not keeping her blood sugars at a nice level and they're going up and down, or she's consistently high, she's giving her baby tons of glucose, and her baby's body makes its own insulin. And so if she's giving her baby tons of glucose, the baby's insulin production's up here. And so when we clamp and cut the cord, we now no more glucose, and that's where we can get that hypoglycemia, right? But because that the baby's insulin production has been high, that is what affects their surfactant production as well. So for this baby that's born to a diabetic mom, we need to watch them for respiratory distress because they could have respiratory distress syndrome if they didn't produce enough surfactant. Okay. Also birth injuries, right? So sometimes moms have to have a C-section if their babies grow too big because of poor glycemic control. Sometimes we'll still deliver vaginally, but there's going to be a higher risk of shoulder dystocia. And if there's shoulder dystocia, now we're assessing this baby for those birth injuries. So we're checking their moral response, and we're seeing if we have symmetry when they startle. We're seeing if this side is not moving well, or this side. I always pick the left. Okay. So this baby born to a diabetic mom has a lot of things we're watching for. Hypoglycemia, number one, but also respiratory, also birth injuries. A nurse examines the breasts of a prima paris breastfeeding mom who is 1 day postpartum. What would we expect our findings to be? Yeah, good. So 1 day postpartum, her breast should be soft and non-tender, and she should have colostrum. When does the milk come in? Does anybody know this?
A
Say
few
about like
days
5 days.
later.
Okay. So I heard a couple different things at the same time. Alicia, what did you say?
I said 5 days.
Okay. And Tamika, what did you say?
I just said a few days.
Uh-huh. And then in the chat we have 3 to 5 days. And so you guys are all just right on track. All right. So it depends a little bit if it's her first baby or not. In this case, it's her first baby, so it probably will take up to 5 days. Typically, if she's had babies before, the milk comes in a little sooner. Once the milk comes in, now we can see engorgement and some of those things. All right, but today for this mama who's 1 day postpartum, she should have soft, non-tender, non-engorged with colostrum. A nurse is documenting assessment findings on a client who's 14 days postpartum, which indicates a normal involution process. Okay. So the normal involution is going to be, it goes down. We said earlier on one of the other questions about a centimeter a day. So at 14 days postpartum, should we be able to palpate it?
No.
No. Okay. Thinking about like a centimeter every day. It should be down where we can't palpate it anymore. As far as the lochia goes, so this one, moderate bright red lochia flow. Should we be seeing red lochia at 14 days postpartum?
No.
What kind of lochia should we be seeing at this appointment?
Cirrhosis. Looked at it
Probably
wrong.
not cirrhosis. It's going to be something else.
Albia.
It should be alba by now.
Oh, okay.
Yep.
So that was one of the
So,
questions on the exam. That's what threw me off.
okay. So usually we are at, we have rubra for like 3 days-ish. Then it goes serosa. Serosa for about 10 days to 2 weeks out, and then it should be alba after that. So by 14 days, we should be at alba. Okay. So for this patient, she should be having lochia alba, and we should not be able to palpate her uterus. In administering vitamin K to the infant shortly after birth, what should the nurse understand about vitamin K? Okay, let's talk about this one. All right. Vitamin K is not going to make the body produce red blood cells. Okay. It's going to help with for hemostasis, for clotting factors. All right. So let me see if I have. One sec. I actually think that in your resources you have the information from the CDC about vitamin K. But the idea here is that we want to prevent vitamin K deficiency bleeding. So let me see if here. Okay. So if we give babies vitamin K, then it's going to help kind of start this process for them to start developing their clotting factors so that their blood can clot normally. Babies that don't receive the vitamin K shot have a higher risk of vitamin K deficiency bleeding, which can typically is in their brain and can cause brain damage. All right, so the idea for vitamin K is going to be hemostasis. And then this part is not initially synthesized because the sterile bowel at birth. So the newborn gut is sterile. It takes a little bit of time to establish the microbiome, and then the body will start making its own vitamin K. So this just kind of gives them that coverage until the body does what it needs to do on its own. Who does RH incompatibility cause harm to? So let's talk about this a little bit because our answers are all over the place. Do you guys remember what's going on with an RH incompatibility?
I really don't understand it. I just know I'm RH negative, and I had to get the Rogam shot when I was pregnant and after I delivered. So, and I knew they said it was a risk to the baby because the blood types or something was going to affect the baby or something to that fact.
Okay, well, that's pretty much it. But let's understand it a little bit better. So if the RH is a protein that either is or isn't on the red blood cells, okay? If you don't have it, then people that do have it, that would be like foreign, right? And so if your baby is Rh positive, that's a foreign thing. If your body sees that baby's blood, it's like, oh, that doesn't belong here, and it starts making antibodies. Okay. With with Rh incompatibility, mom is negative, like you are, and the baby's positive. And it's going to affect the baby, but not this time, not with the first pregnancy. Because remember that mom blood and baby blood isn't supposed to mix. So there's very few opportunities for your blood to see that baby's blood type is something that appears foreign to it. And And so we give RhoGAM so that if it sees it, it doesn't build the antibodies.
Okay.
Does that make sense?
Yes.
So on another pregnancy, if that baby is also Rh positive and you didn't have the RhoGAM, your body would have made those antibodies, and those antibodies can then attack the baby's red blood cells. So we give RhoGAM to moms that are Rh negative. We give it to them at 28 weeks. We, after the baby's born, we check the baby's blood type. If the baby's blood type is Rh negative, we don't need to give you RhoGAM again because there's nothing happening there. But if the baby's Rh positive, then we give you RhoGAM again. Also for moms that have things like trauma, which could cause the possibility, because there's only like a single cell membrane that keeps the mom blood and the baby's blood separate. So trauma could cause a little bit of a disruption of that. And so trauma would be a time we would give RhoGAM. Miscarriages, we don't know if the baby's blood type was positive or negative, so we'll give RhoGAM then.
Right.
But the RhoGAM is just to prevent that immune response from happening.
Okay.
So on the question, when it says who is at risk or who does it cause harm to, it's only going to cause harm to the baby. And it's not going to be the first baby. It's going to be subsequent babies if we don't give RhoGAM, because the baby is the one that's going to be affected by that immune response. It doesn't affect you either way. But if your body builds up immunity to it or doesn't really matter for you. It only matters for the baby. Okay. Everybody else good with this? I'm going to go with yes. The nurse applies erythromycin eye ointment to a newborn's eyes after delivery. The nurse explains that it's used for what purpose? Okay. So ophthalmia neonatorum is the conjunctivitis that babies can develop. And which babies are going to be at risk of developing ophthalmia neonatorum? Babies exposed to what?
Chlamydia.
Mm-hmm. And there's one other one.
Gonorrhea.
Yep. And we're going to give this to all babies. Okay, even if you tested mom at the beginning of her pregnancy and she was negative for chlamydia and gonorrhea, you don't know if she's contracted it throughout the pregnancy. And this is just an easy thing. It's one-time ointment in the eyes, protects, because the babies can have blindness from this if they develop it. So we just give it to all babies as a standard unless unless the mom chooses to decline it. How can the nurse decrease heat loss by evaporation? Okay, so in order to decrease heat loss by evaporation, we need to dry the baby. Oh, I thought I paused it. So drying is going to be the one for evaporation. You have to think about all the ways babies lose heat, and we don't want them to get cold. Which of the following characteristics will distinguish a post-mature neonate at birth? Okay, post-mature is going to be like greater than 42 weeks. We're not going to really see vernix on these babies. Their skin can be dry and cracked. Okay. The other options, lanugo is like the little hairs that can be on their skin. And then Vernix is that white cheesy substance that is on babies that helps protect their skin since they're in fluid for, their whole life up till then. And as they get close to delivery, this stuff starts going away. What symptom assessed in the newborn shortly after delivery should be reported? Okay, good. This one, sternal or chest retractions, right? Remember the things we talked about for respiratory distress. Okay. Retractions, nasal flaring, grunting, seesaw respirations, tachypnea. Now this one, two of you picked green, mucus draining from the nose. I want you guys to remember that these babies, again, using the pediatrician's analogy, these babies have been living in a fish tank. Okay.
Okay.
So having fluid draining out of their nose is a normal thing.
Okay.
Okay. Their bodies have to adjust from being in water to not being in water. And so it's not abnormal to see that. But the retractions would be concerning because then that's your use of accessory muscles for breathing. So that's a sign of respiratory distress. Babies can have an irregular heart rate. That's normal. They have irregular breathing and irregular heart rates. And acrocyanosis is if we have blue hands and feet with the baby's pink all over. That's normal too. When the newborn's crib was bumped, the nurse noticed that his legs flexed and his arms fanned out. What is this? Okay, so we talked about this one in relation to when we were assessing for clavicle fractures and brachial plexus injuries. This is the startle reflex or the Merle reflex. Okay, this is one of the reflexes we assess when we're doing our head to toe assessment. Why do you think it's important for us to assess reflexes? Just because? Is the because I said so rule?
To see if they have neurological problems.
Yeah, good. All right. So this is a really good indicator of if they're having any neurologic issue. We will, if we have a baby that we're really worried about, like had a lot of, maybe they had a bradycardia, like a cord prolapse. Maybe they had a bradycardia. They came out with a really low APGAR score. And we're watching them neurologically. One of the big things we'll check is their reflexes, especially their suck. The suck is a really good indicator. Okay. Also, we can use them like the Merle reflex to assess, right? If we have symmetry or if we have like an injury, we can use it also like the rooting reflex. Do you remember rooting? Like if you stroke their cheek and they turn, which can kind of help with breastfeeding. So there's a lot of different reasons that we use it, but the main one is to assess for neurologic. What action does the nurse implement to protect infants from infection while in the nursery? Yep, washing our hands, washing our hands, washing our hands, and then we should also wash our hands. When assessing the APGAR score, which normal finding could cause a newborn to lose points? Okay, so normal finding on our APGAR score that causes a newborn to lose points is acrocyanosis. So let's remember for a minute how we do APGAR score. Okay, because that's kind of its own whole thing, right? So what are we looking at on an APGAR score?
Their color, their cry.
The way they make faces, I'm assuming. The appearance they come out, if they're blue all over or in certain areas.
Hmm?
Do they have any type of respiratory problems?
Okay,
How high is their heart rate?
okay.
Um, that's all I can think of.
Grimace, pulse, grimace, activity, restorations. Okay, APGAR is an acronym. So for color, you guys both said color. So this is where you could lose a point on your APGAR score, but it's still normal. That's your acrocyanosis. Because they need to be completely pink to get 2 points. If they are pink everywhere but hands and feet, they get 1 point. But that's still a normal thing in the first 24 hours of life for them to have acrocyanosis. And then if they're blue all over, they get no points. Honestly, guys, a lot of the times on that 1 minute APGAR, I assign no points on color because babies come out kind of bluish, grayish, pale, and it takes a little bit of breathing and crying for them to pink up. Okay, so, but by 5 minutes of life, usually we'll see acrocyanosis, and the body should be pink by then. For pulse, what's normal before greater than or less than what?
Is it 140?
Not for this. It's
Okay.
surprisingly lower. It's surprisingly a lower number than I would have thought.
Okay.
Maybe like 110 or like 80.
A little bit less.
Oh.
80.
Not less than 80. Sorry, not less than 110. So our number for pulse is going to be greater than or less than 100. So if they have a pulse greater than 100, they get 2 points. If they have a heart rate less than 100, they get 1 point. Unless they have no heart rate, then they get no point.
So their heart rate is higher in utero versus.
No, so this is only for APGAR score. So truly, a newborn's heart rate should still be 110 to 160.
Okay.
But just for APGAR scoring purposes, if the heart rate's greater than 100, they get 2 points. If it's less than 100, they get 1 point. So we use 100 just for this.
Okay. Okay. That's basically
Okay.
the baseline for the score. Okay.
Okay. Yeah, it's just for the score.
Okay.
All right. We still expect to see the same heart rate as in utero.
Okay.
Yeah. Okay. Grimace, you did a good job talking about like how their face looks. So it's really kind of difficult to describe grimace, but it's really how your baby responds to stimulation. So if I am using the bulb syringe and sucking out their mouth, that's stimulation. If they're going like, get away from me, you crazy lady, then she's just a good grimace. If I'm rubbing them, one thing I'll really do to kind of try to make a baby cry is rub their feet because they hate that. If they're pulling their leg up, like stop grabbing my foot and making that face, that crunched up face, then that's a good grimace. Now, if they're just making the face, but they're not really moving around and trying to get away from whatever's annoying them, then I give them 1 point. Okay, so they need to be trying to, like, they need to be actively responding. Does that make sense for grimace?
Yes.
Activity is if they're moving around, they're moving their limbs, 2 points. If their limbs are flexed, but they're not really moving a lot, then 1 point. And then if they're limp and floppy, they get no points. And then for respirations, if they're crying, so we use words like vigorous and lusty to describe this really strong cry that is really reassuring. So if they have a vigorous or lusty cry, they definitely get 2 points.
Okay.
If they aren't crying and they're breathing, but they're still just kind of working it out, they might get 1 point. And if they're not breathing, they get no points. Okay. So when do we do APGAR scoring?
Is it 1 minute, 5 minutes, and 10 minutes?
So every single baby will get 1 minute and 5 minutes.
Okay.
Every baby. How would I decide if I needed to do it again in 5 more minutes at the 10-minute mark?
If it's less than I guess less than 8. If
Less than 7.
okay,
So if
let's
it's 7, 8, 9, 10, we don't have to do it again. Okay, because 7 or better is really giving us a pretty good indication that our baby is adjusting to being, that's the whole point of an APGAR score, is how's the baby adjusting to extrauterine life? How are they adjusting to being a land animal instead of a fish? Okay, and I'm totally joking, babies aren't fish. I don't want to actually cause any confusion by that. But how are they adjusting to the fact that they're not in utero anymore? And so these are the things we assess. And then if it's 7 or better, we don't need to keep assessing. If it's less, then we need to reassess every 5 minutes for up to 20 minutes, and we'll still be doing interventions in the meantime to try to improve that score. So if my score is less than 7, I probably am seeing if I can also have other friends come help. Maybe calling the provider. Okay. The nurse is assessing a newborn's reflexes. Which response will, oh my gosh, which response will cause the nurse concern? Okay, so we talked about this already, that if we're having an absent suck reflex, that's really concerning for a neurologic impairment. These other ones are all good findings. Which action best explains the main role of surfactant in the neonate? Okay, good job. So the surfactant is going to help the lungs remain expanded after initiation of breathing. So it's going to, we talked about that before, right? That if we don't have sufficient surfactant, then we can have atelectasis, and these little alveoli air sacs can kind of collapse down, and it's hard for the baby to get them to open back up. And so surfactant is going to help keep those open. You guys did a good job with that. Which of these are signs of cold stress in the newborn? All right, all of these are signs of cold stress. All right, so we have to remember, guys, that if our baby gets cold, they can't shiver to get warm. And so it causes everything to like vasoconstrict, and that's going to decrease the oxygen to the tissues. And so with this, we can develop a metabolic acidosis. And so what we might see is that mottled skin, a bradycardia, a weak cry, hypotonia, lethargy. We also can see tachypnea here because they're trying to oxygenate, so that your body starts breathing faster to try to oxygenate because we're having a decrease in oxygenation to the tissues with this. Okay, so all of these are symptoms of cold stress. The newborn exhibits respiratory distress, weak cry, jitteriness, hypotonia, and lethargy, and the temp is 96.9. What is the first priority?
I got that one.
All right, so remember we talked about how a cold baby can then also cause the baby be hypoglycemic. So yes, we need to warm this baby. And this baby at 96.9 probably needs to be on the radiant warmer. Does anybody know how we use the radiant warmer? Check the chat box. Okay, chat box says no. I was expecting some profound answer. It says no. That's fine. So let's talk about the radiant warmer for a second. So with the radiant warmer for our babies, so the best place for our babies is skin to skin, right? But if our baby is 96.9, they're not staying warm skin to skin. So we might use the radiant warmer to help warm the baby to an appropriate temperature. And we put the baby on the radiant warmer. They have this little thermometer that you can put on their belly, and you plug it in and you set it to the temperature you want the baby to be. And then the radiant warmer adjusts its own heat until it gets the baby to the temperature that you set. So for a baby that's this cold, I would probably warm the baby on the radiant warmer. Okay. Swaddling is not going to be enough for that baby. And if my baby's a little cold, I'll do skin to skin with a warm blanket. But if my baby's that cold, I probably would do the radiant warmer with the little servo temperature. Okay. So for this baby, I would check the blood sugar because I'd be really concerned that this baby is hypoglycemic, partly because we have signs of hypoglycemia, right? And partly because that, but see, some of these symptoms could be related to cold stress, but that's also going to cause hypoglycemia. Okay, so remember they kind of go together. So this baby needs to be, we need to check the glucose. It's going to be really important that we're managing if the baby's hypoglycemic, and then I probably would put the baby on the radiant warmer. But glucose first. The nurse is admitting a newborn to the nursery and places, oh, I didn't even know I had this question. Places the infant under a servo-controlled radiant warmer. Which action is the most critical nursing intervention for the safe operation of this device? You guys should all get this one right because we just talked about it. We're going to put the temperature probe on the baby's belly. Okay. And then we'll set it to the temperature that we want, and it'll adjust the baby's temp. A nurse is caring for a newborn after circumcision. What education should the nurse provide to the parents? Okay, good. We're going to use petroleum jelly at each diaper change. We don't need to do antibiotic on it. We don't need to do a cold compress. And we don't need to do a sterile dressing. Okay, but the petroleum jelly is going to be important because I don't know if y'all have ever seen a newly circumcised baby, but the head of the penis is really red and really angry. And it has a little bit of like just normal drainage, and it can dry and stick to the diaper, and then taking that off would be very painful and disrupt the healing process. So petroleum jelly is going to protect the head of the penis so it doesn't stick. All right, and I usually do it with a 2x2, and I put the petroleum jelly on and I just set it on top of the penis that way. The nurse is presenting education for lactating mothers. She emphasizes that the optimum time to initiate lactation is when? So you guys all did really well with this. We want to try to get that baby feeding in the first hour if possible. Because part of it is you see in green where it says during the infant's second period of reactivity, babies have a period of reactivity when they're first born, then they get really sleepy, and then they hit their second period of reactivity, which is going to be much later. So you don't want to wait till the second period of reactivity, and you don't want to wait till the baby's sleeping because it's going to be hard to get a good latch. And that latch is going to be so important from the very first feeding. So we're getting babies belly to belly. We want that nice deep latch so that we're not causing tissue trauma to the nipples. And so as soon as we can get a baby latched after they're born, the better. The baby's vital signs are 96.5, heart rate's 120, respirations are 40. The infant is pink with acrocyanosis. What is the priority for this baby? Good. All right, we talked a lot already today about cold babies. So respiratory is number one, but thermoregulation is a close second for newborns as far as priorities. When performing an assessment on neonate, which assessment finding is most suggestive of hypothermia? Okay, so remember babies can't shiver. All right. So if their temperature is low, bradycardia is going to be a sign. Mottled skin, cool to the touch, things that are like slowing down, so lethargy, poor feeding. Okay. Two more. Vitamin K is prescribed to the neonate. A nurse prepares to administer the medication in which muscle site? Good. All right, it goes in the vastus lateralis. Which finding would the nurse expect to see during the assessment of a newborn born to a mother addicted to drugs? Okay, good. So remember with this, guys, if your baby is withdrawing, everything's up here. All right, so they're not lethargic, they're not snuggly, they're not sleepy. One of the things that we try to do is, as a treatment method that's non-pharmacologic, is eat, sleep, console. So we look at, are they consolable? Are they sleeping? And are they eating? And if they're not, then we have to kind of look further into whether or not they need pharmacologic pain management, or not pain management, but pharmacologic management of their withdrawal symptoms. The incessant high-pitched cry is a symptom. Okay, it's a big symptom. Yay! And Tamika started the game late, so. All right, questions, thoughts? Nothing? I'm gonna stop our recording.